order. We'll start with the consent agenda. All the following items which concern reports and items that were routinely normally approved at AHA meetings will be approved by one vote unless any trustee desires to have a separate vote on any or all these items. The consent agenda consists of the discussion, consideration, and action on the following items. Minutes of the regular trustee meeting, June 28, 2022. Minutes of the special finance meeting, June 28, 2022. Minutes of the special finance meeting, August 2nd, 2022. Minutes of the regular finance meeting, August 16th, 2022. And check report, June 9th, 2022 through August 8th, 2022.
I make a motion that we approve the consent agenda, items A through E as presented.
Second.
We have a motion by Dr. Brown, a second by Dr. Simon to approve the consent agenda as it was presented. Roll call vote, please.
Gasper,
Yes.
Hannaford,
Yes.
Simon,
Yes.
Brown,
Yes.
Bowman.
Yes.
Okay. Next item is the CEO's report. Candace?
All right, you got my snapshot that I sent you earlier. If there's anything, any questions you have about that, I'll run through some of that real quick. Meditech as a service is our implementation project that we're working on to replace our current EHR. Meetings going on and preparing for that implementation is ongoing. Revenue cycle with HRG, we have another meeting tomorrow. I feel like that's going good, and Chris may talk about that, or Angelica may talk about that a little bit more if you want. The InReach project, we are getting closer and closer on that. We are in the process of identifying financing for the upfront equipment that we will need for that. So that's moving along. Skipping on down, supply chain management, was not able to meet with Clark Kauser. He actually got sick. I'll see him on Thursday and we will talk about supply chain management at that point. What I'm trying to do on that with Anita is getting closer and closer to retirement age. Obviously a lot of knowledge is gonna walk out the door when she retires. And I think that this is a great opportunity for us to look at some options and maybe even partner with SSM. They're interested in talking. They think it has legs to talk about doing something because I think it could benefit all of the affiliates. With supply chain management being your second biggest spend next to salaries, you have a big opportunity for savings, I believe, and maybe to do things a little bit different. For instance, you know, if we have to order something in cases, you know, if you have to take so many cases or even just one case, we may only use 2 out of something that may come in 48. So being able to split that with the affiliate partners would be a savings, but you know, just taking a really deep dive into those contracts and making sure that you're getting the best contract pricing on all of those things is the topic of conversation regarding that. Like I said earlier, getting good feedback on the ER providers, Dr. Cook and Sean Brandenburg, the PA. We're very excited to have them and it seems to be going well. Next, for administration, Angelica is doing a great job. She's really jumped in and is a huge asset to our organization. I really appreciate her help. I was gone on vacation for a week and I got lost in the middle of the ocean, and you know, it's sink or swim, and they swim. I mean, literally that was Kelly, were you and I have, yeah, Kelly and I had that conversation today. I said, you know, the goal is for me to be gone. I've done my job if I can walk out the door and they don't miss me. That is my goal. I don't want them to miss me. I want them to be self-sufficient and to be able to problem solve and to carry on without me. So they did a great job of that, and I appreciate that. Chris is transitioning to his new role and is doing a wonderful job. I think that with having Forvis, which used to be BKD, in here, and giving him the opportunity to take a dive into our revenue cycle and learn about those things and what we can do better to serve our customers. We're looking forward to that day when we don't hear any more complaints on our revenue cycle. But it's obviously a huge undertaking. They've been in here for a few months now, and I feel like we're just, have reached the tip of the iceberg on it. It's a huge project. They will be with us for a long time, and that tells me that it is a very tedious project. There's a lot involved. I don't think any of us realize what all goes into that. So very thankful for their guidance on that. I did say it in my little snapshot, small remodel project going on in the conference room. We're trying to make space, utilize the space that we have a little more efficiently. And so we'll be purchasing some smart boards for training, particularly the implementation project with the EHR and COVID. It allows us, like right now, you can see kind of where we're sitting. This isn't very attractive. You really don't want to invite people into this space if you don't have to. This will get a facelift. We're going to move that wall out a little bit, and it will be big enough then to accommodate all of our staff training that we need. Hi, Dr. Burt, come on in. He's there.
Right here.
What's the time frame on the renovations?
On the renovations. Shouldn't take too long. They've been working on the conference room, the media room where we're usually at. They've been in there for about 2 weeks now. Don't have a lot left on that. We'll do carpet in there and some cabinets, and then they'll move down here. That wall will be pushed to the west as far as we can go, and then the front door of this classroom will be in the hallway. And there'll be probably a couple of smart boards in here, some tables and chairs. They suggested we had 3 training labs, so we'll do these 2 rooms, and then we'll be utilizing the PT, old PT room over there as a temporary classroom space as well. So the last thing I have, I want to brag on the nursing staff and how well they've done. I've told you throughout, COVID, how well they've picked up on the training, and we've gotten a lot of equipment in that they were able to use. This is from Dr. Gulliford, who is our, Daryl Gulliford. He actually teaches over at Autry in Enid. He works for OU as well. He is our consultant respiratory therapist that we have that does the training for the nurses. Since we don't have respiratory therapists at Share, he teaches our staff to be respiratory therapists basically. And so I just wanted to read you a letter that he wrote to Regina and I in recognition of what they've done. He said, I had the opportunity to speak at the National Conference of the American Association for Respiratory Care last month. The conference was held in Palm Springs, California with about 900 attendees. My topic was cardiopulmonary care in small and rural hospital settings. I wanted you to know that I use Share Medical Center as my example of how cardiopulmonary care can be conducted at a very high level, even in a small facility. I've worked with many small hospitals in Ohio, Kansas, and Oklahoma over the past 30 years. But among small hospitals, nowhere is the care of patients more current and more proactive than it is at Share. Having worked with your hospital for 11 years now, I see several reasons for this. First and foremost, nurses who are willing and ready to learn whatever is needed for the patients. The not my job attitude does not exist on your staff. Physicians and other providers at Share who will listen to the nurses and to myself when we have recommendations or when we need a provider's order for something important. You have created access to leaders in each professional field, and you realize that it will not be possible to have all of them residing in Alva. You have them joined by phone, by Zoom, and by telemedicine. I just wanted you to know that the National Respiratory Care community is now aware of Share Medical Center in Alva. There are 1,353 hospitals in America with 25 beds or less. If they all had approached cardiopulmonary care as Share does, we would improve rural health care in the nation. Dr. Goldberg.
Wow.
It's a huge pat on the back.
Yeah.
Anyway, shout out to them. Does anybody have any questions for me?
I'll add to that, Candace. A few weeks ago, we had an opportunity to take a patient from another hospital, I'll just leave it at that did have respiratory therapists on staff and did have many more resources available to them than what we have here. And the family and the patient really wanted to come to our hospital, and I got involved with it because there was some consideration of going to the nursing home instead. You know, working with Regina and Jane as well as the family just wishes that the transition to share had been so much sooner, because even with all the resources available to them at the other hospital, we did more for them in the short period of time that they were here at the hospital than they got in the multiple weeks that they were at the other hospital. So they were, it goes right along with what he's saying.
Very good. It's good to hear.
Kudos to all around. I'm assuming that's been shared?
Yes.
Very good. Any other questions for Candace? If not, I would entertain a motion.
I make a motion to approve and accept the Sheriff Medical Center written report for August 30th, 2022.
Had a motion by Dr. Hannaford, a second by Dr. Simon to approve the Sheriff Medical Center written report for August 30th, 2022. Roll call vote, please.
Hannaford,
Yes.
Burke,
Yes.
Simon,
Yes.
Brown,
Yes.
Bowman. Yes. Casper.
Yes. All right, Candace, thank you. Next is the CFO's report.
All right, I'm a little nervous, so you'll have to bear with me as I stumble through this. So I wanted to talk a little bit before we get into the financial statements. You know, we've had a lot of short-staffed areas between housekeeping, maintenance, reception, you know, all the different places that we have besides, you know, our doctors and our nurses, and we have short-staffed there as well. But our teams have really stuck together, and you know, we've had people come in and help housekeeping, or people come up and help registration, doing things that aren't necessarily their jobs, and I really appreciate, you know, their willingness to have some flexibility and learn something new or do something new. You know, they're learning about me as I'm learning about them, and definitely a teamwork standpoint is a teamwork approach is what I want to take, and they've really embraced it and really stepped in, and I've been very appreciative of the staff that they're willing to do that, willing to learn something new. Candace talked about the charge master review. I did visit with them today. I know it sounds like we're in the final stages of that review. I'm hoping to have a final report within the next 2 weeks. So it's been progressing very quickly, a lot ahead of the schedule that they had originally given us. So our revenue cycle team, they attended a Medicare boot camp last week. They were able to go and spend 4 of the 5 days in the city together, learning about all things Medicare and RHC as well. So I think that was really good team building for them, and then the ability to learn some new things. So I was very excited that they were all willing to spend that time away with their family and go do that. We've also began, you know, Meditech as a service. We've been working through our interfaces, what interfaces we have, what interfaces we're going to need, what does the future look like for us. And we've had 2 calls on that so far. We'll begin having weekly touch base meetings with the interface team and start walking through that process next week. And I anticipate, I think we're learning a little bit about our people that we're working with there on the Meditech side, having some more conversations and trying to figure out what our needs are and what their needs are. And Candace has really talked to our team about making sure that if we don't know an answer, it's okay to say we don't know the answer and try.
Don't make it up. And I think we've made the decision since we met last. Angelica is the project lead on the Meditech implementation. I just think that will be helpful for her to know that inside and out, and to be able to, you know, think about, okay, that entire process, how that, you know, when we answer those questions on those forms or questionnaires or face-to-face, how it affects, you know, downstream in the process. There's several. We've got Chris Burke is going to be the physician liaison. Mark Almack will be kind of our clinical analyst, and we've got a good group of people, well-rounded, that will be assisting with implementation.
I think it's so far, I mean, we're learning a lot, I'll just say it that way. And working with staff to tell us what they don't know so we can find those answers. And trying to figure out where those resources are too, so. Those are all things outside of the financial statements that I wanted to talk about, but we can jump into the financial statements now. Let's see. Both July and June financial statements are in your packet there for your review. I'm going to talk about the July ones that kind of jump back and forth into June as well. So our operating cash balance for the month end of July was $33,500. You know, we've been seeing over the last couple months a decrease in our cash balance, which my understanding is fairly normal for this time of year. You know, we have, if you look later on, you'll see that we got a reduced number of inpatient days, a reduced number of clinic visits as well. You know, we've also had, in the month of July, we had 3 payrolls, 4 AP runs in that time frame, and so that does strain our cash a little bit. And the last day of the month was on a Sunday, so we didn't really have any day to recover or any time to recover there as well. I anticipate that we will see an increase in cash, you know, coming into August and September. We did have some Medicare billing issues that we're still wrapping up. I think we should have most of those resolved by the end of this month, so hopefully we can get through all of that. And we did, I know we talked about at the last board meeting, we had some Medicare penalties that we were also dealing with, and so that kind of reduced our cash flow as well. So hopefully we should be through those rough patches. We've already seen an increase in clinic visits. I know the urgent care has been slammed, ER has been extremely busy as well, so I anticipate that we'll see an increase there. If you look at our days in accounts receivable, you can see that even just between June and July, we've had a decrease in total AR days from 101 down to 88.8. That's where our revenue cycle review that we're doing with Forbes has really come into play. They're really helping us work to get those numbers down. You can see our KPI that we're striving towards is 61 days. So, you know, we're getting closer every little bit. Our accounts payable balance, you can see that it was about $467,000 at the end of July as well. We talked about hospital gross patient revenue. So if you look there, we had, for the month of July, about $1.4 million, which is a decrease from last month. Kind of talk about the impact there of cash flow and how our total patient days were down to 63 compared to 97 in June, and our office visits were down to just under 1,300 compared to 1,450 in June. So very typical for the summer months. You know, as we get back into the school season and everybody's getting close to everybody, we'll probably see an increase there. Let's see here. Charity care for the month of July was about $5,000. You know, when you look at our total net loss for the month of July was a net loss of $442,000. So, talk about a variety of things. I know Chris usually walks through like the next page where we've got the 6-month comparison. So you can kind of see our gross patient revenue is down for July. An increase in June, but down for July. Our bad debt allocation is back on track. I know we've had some decreases to that over the last month. We're back on track, and the allocation is $130,000 this month. Our other operating revenue, we don't have a whole lot there. I know in previous months we've had, COVID revenue that has come in. We've not had any COVID revenue for a little bit. So total operating revenue of about $530,000. If you walk through our expenses, we don't have a whole lot of changes there. About a little over $1 million in expenses. If you would like to look at the expense detail for other expenses, you can look at the next page, and it walks you through that $187,000 total for the month of July. What questions do you guys have for me related to the financial statements? You guys are very talkative.
It's because you did such a great job.
I'm sure that's what my name.
Yeah.
I'll get better as we go forward.
Is the 2-year comparison on page 4, am I reading that the year-to-date 220 for FY23 to 442 is the same as the ending for July 22?
It would be, that's our only one.
Good, yes, because it's just the
Oh, first, I got you.
first month of the fiscal year.
Yep, I got you. I was going backwards.
If you guys don't have any questions like Kelly, I'll let you talk about the homestead and the nursing home.
Okay.
Can we do that now?
Yep.
Oh, yeah.
Yep, okay, that's fine, the financials. We do
We'll
that.
do it. Nursing home did, so for July, we had operating cash balance of about $331,000, and that's about 37 days of expenses. We did increase our AR by about $63,000, so we're at about 1.5. It's still on accounts receivable. Our accounts payable is down $61,000, and so we're getting our bills paid in about 20 days. So that's pleased with that. Revenue for the month of July was $222,000, which is pretty consistent with where we've been. It was an increase of $140,000 over the previous month, but in the previous month there was an adjustment to make up for an error in the contractuals for I think back in April. So those kind of offset each other. But at the end of the month, we had a net loss or net income? Net income. It says net loss, but it's a net income of $13,390. And so July, it was not a bad month. We continue to, if you look at the 6-month comparison, you can see all that there. Obviously, year-to-date, it's going to be the same as the month of July. Probably the main thing that's kind of having an impact on us right now is that we haven't had as many skilled nursing Medicare Part A stays. We also have had, and some of this is reflected in July, but most of this has come in August. But we've had several deaths over the last 6 weeks, more than what I would say is normal. But I mean, there weren't anything that they were anticipated based on the condition of the residents, but it's just more than what we're used to. And so we have that, as well as a staffing ratio right now for our nurses and nurse aides compared to our number of patients is, in order to keep that where it's at, we're having to limit admissions so that we make sure that we've got enough staff to take care of the people that we have. We're having a lot of difficulty just getting applications for nurses and nurse aides, well, all positions. All positions. And it's not just here, you guys see it in your work too, I'm sure of it. That's, to have the revenue kind of be remaining a little bit flat, that's been good. But with that, we're having some overtime, and we did, I hate to say this, we did have to have some agency nurse aide and nurses in the month of July and August. So, but that is kind of the finances for the nursing home. Does anybody have any questions? All right. On the homestead, the homestead in July had just over $50,000 in revenue, which was up about $3,500 from June. We had almost $57,000 in expenses, which was a little bit high, well, higher than normal for the homestead. And so we had an operating loss of about $6,700. The primary reasons for that increase is with utilities, and it looks like to me it probably some carryover from the month before where we didn't just kind of cash in and cash out. We might have paid 2 months worth of utilities, it looks like in July, because it was only $900 in June. So that with a slight increase in supplies, only a slight increase in salaries. That's going to be the difference there. So we did show a little bit of a loss for July.
What's our census over there now, Cal?
Census
over here.
is, in July, it's 24.8. So that's a occupancy of about 45%. There is some more advertising taking place in the Enid area. We're very competitive on pricing, and even with a significant price increase, we would be very competitive in pricing for what we have. So we're trying to get out into some of those markets where we might be a more cost-effective option for people if they know about us. So.
Okay. Any other questions for Kelly on the financials or Angelica? If not, we can move on to item B, which is discussion action to approve or disapprove the purchase of a, they say that, CP? PCR analyzer in the amount not to exceed $61,181.
So this is a purchase that would be, we would be able to use COVID funds for. It would allow us to perform the PCR test here in our lab and not have to send it off. So it would reduce the expense that we have going into those tests. I believe it's a 4-chambered machine, so it would allow us to do 4 tests at a time. It can also be used for strep and a variety of other things.
What COVID, strep, flu?
COVID, strep, flu. There was one
Mono?
more. Mono.
I think I'm on a spot.
And we have COVID money to cover that whole cost.
And we need to use these COVID funds before the end of the year.
That's one thing I was going to add, is part of the reason for redoing this to a bigger area. When we had our last surge of testing, we ended up having to, use the clinics for to use urgent care for COVID testing, and everybody else then went to the clinics for everything else. By making this a bigger space, direct access, from the outside, we feel like we could do it like a COVID testing center in here. They would come in through that basement door there, come here. We wouldn't have to have sick people all amongst everybody else upstairs. So that's what this room will provide for us the next time around.
So this is just for the analyzer? What about reagents and the testing equipment to do the test?
Like the supplies?
Yeah, the
usually.
supplies and reagents. And
I mean, so Coca didn't really give us that information.
I
that gonna
didn't
be
talk
the-
to her specific about that. A lot of times when you buy that equipment,
Yes.
you know,
you're locked in,
you're locked into using a special, you know, those,
That certain.
the reagents and
Yeah.
stuff.
but that's not uncommon. That's typical with all of that
I
lab
was just wondering
equipment.
if it was reasonable priced
Yeah, I'm sure.
to where we're not gonna
Yeah, we
lose
save,
money on every test.
well, she actually said on every test.
No, it's just
we-
save money.
We've been,
Okay.
we typically would spend about $100 a test, and
Mhm.
with this, it actually would drop our expenses to $30 a test. So we're
Wow.
saving money for every test.
Gotcha.
We may pay a little more, I don't know about the reagents, but we save quite a bit on every test. Instead of sending them off,
Hmm.
waiting 5 days, we have a turnaround of, I think
Hours.
she said it was just hours.
Yeah.
Hours PCR.
2 to 3 hours.
But yeah, we save about $70 a test.
Sounds good.
Are there any other questions in regards to this PCR analyzer?
Is there any software updates you have to pay for periodically for the machine or any of that stuff ongoing,
She, no.
just a one-time deal?
It should be, yes.
Probably a lot like the Sophias that we have. Do you have a Sophia at your office? The flu,
Oh, yeah.
the quick test. It's probably a lot like that, with no more cost than that is. I mean, that's 61,000, but for a piece of lab equipment,
Right,
that's,
that's cheap.
yeah.
Make a motion to approve the purchase of a PCR analyzer in an amount not to exceed $61,181.
Second.
Take your pick.
Is that Greg?
Yes.
Try to get them rock, paper, scissors.
All right, I have a motion by Dr. Hannaford, a second by Greg Bowen, to approve the purchase of the PCR analyzer in the amount not to exceed $61,181. Roll call vote, please.
Simon?
Yes.
Brown? Yes. Bowman?
Yes.
Jasper?
Yes.
Hannaford?
Yes.
Burke?
Yes.
Okay. You did well. Good job. Thank you for your first report. Next, we have Dr. Burke with the Medical Staff Executive Committee.
Makes you feel any better? I've been doing this for 9 months and I still get nervous. So, just let you know. So since our last meeting, medical staff met twice, once in July and once in August. In July, there was no agenda items to vote on. And in August, there were 2 credentialing committee reappointments and appointments that were discussed and reviewed. So we don't need a motion on the minutes, do we?
No.
Okay. So in August, we had, the credentialing committee had 2 providers that came up. The first one was Stephen Danley for a reappointment to courtesy staff. He's a sound physician, I believe. And he covers the inpatient hospitals periodically if somebody else is out or ill.
Okay.
And so,
Okay.
any questions on that?
I would entertain a motion.
I make a motion that we reappoint courtesy staff, Stephen Danley, DO.
Second.
Have a motion by Dr. Brown, a second by Dr. Hannaford to reappoint the courtesy staff Stephen Danley, DO. Roll call vote, please.
Brown? Yes. Bowman?
Yes.
Jasper?
Yes.
Hannaford?
Yes.
Burke?
Yep.
Simon?
Yes.
I guess I should say yes.
Can't go wrong.
Okay. And The second credentialing committee item was the appointment to allied staff of Sean Brandenburg, who is our new PA that's covering the emergency room. And just to let you know, I've heard nothing but good things about him so far.
Good deal.
Everybody that's been in the ER and has met him said great things. So we did good there.
Yay.
Well, and likewise, I met him, and he had nothing but good things to say about Share Medical Center. He says, I've worked at several places, even up around Wichita and whatnot, and he goes, this place has it going. That's what his comment was, so.
Hopefully it'll stay.
There you go.
I make a motion, we appoint to allied staff Sean Brandenburg, PA.
Second.
Have a motion by Dr. Brown, a second by Dr. Simon to appoint to allied staff Sean Brandenburg, PA. Roll call vote, please.
Bowman,
Yes.
Casper,
Yes.
Hannaford,
Yes.
Burt,
Yes,
Simon,
Yes.
Brown.
Yes.
All right.
that's all I have.
Thank you, Dr. Burton. So this is August. We don't have anything for coffee, is that correct? But we do have improvement to patient care.
Coffee August 4th.
Okay.
Yeah, we do.
All right, then I'll let you
Nothing
take
in
over.
particular.
Okay, sorry.
No, it's okay. Skip it if you want to. So obviously continue to work on all things quality related. And I really don't know what we would do without our SQSS software that helps us keep track of all things quality related. And when I say quality related, think in terms of basically everything we do in the hospital. It keeps us on track with all of our tasks, all of our PM and equipment, our maintenance on our equipment, daily tasks that all of us have to do. Whether it's patient care related, lab related, x-ray, all of those things. This is kind of the master to-do list for all of our staff for daily, weekly, monthly,
How many
quarterly.
tasks are in there?
Oh, so, yeah, well, let's talk about that for a minute. So, we're doing such a good job that the lady that built the software developer for the system, Darlene Bainbridge, thinks we're doing such a good job that she signed us up for for the National Rural Health Association Conference in Kansas City next month. We were one of 14 presenters out of 72 that was chosen to present. So, yeah. So, I was thinking, okay, yeah, 1 in 72 chance. Okay.
She's very excited about it.
I'm so excited. So Coco Burton, Regina Wilson, Amber Jewell, and I will be presenting. They think they're going to sit there and watch me present, and that's not how this is going to go. No. We'll all be involved. We actually have a meeting tomorrow to go over our slides and presentations. So we're excited. We're excited to showcase all of our work. Chris is referring to the over 25,000 tasks that we have in SQSS at this point. All of those are Share Medical Centers. This does not come pre-built with tasks in them. It's kind of like Meditech. You kind of get an empty shell to fill in, and you build it to be your own. And we've had this system for 6 years or so. But really in the last year we've embraced the use of it, and it kind of clicked with, particularly with me in another respect. Shared it with Kelly, and Kelly's like, I want to kill you for not telling me about this sooner. Because it really does. If I need Dr. Burt to do something for me, I can put that in SQSS. I can set a time that it needs to be completed by, and it reminds him, it reminds me. And if he doesn't resolve it by that date and he hasn't updated it, it just reminds that person requesting it to not drop the ball and to keep going until we get it resolved. And that's really, when we had our last DNV survey, which is our accreditation survey, it went super fast because the surveyors are able to sit down and we've got at our fingertips what we used to be running around trying to find. If that person happened, that owned that process, that book happened to be gone for the day and you couldn't locate it, it's very unnerving to not be able to put your hands on what you need. We've got all of our policy and procedures. We're getting closer to having all of them on there, but we've got the majority of our policies and procedures on there. Kelly will be working on his in the future. It's a long process. It's not something that you can even tackle in a year. It's an ongoing process that you continue to build. And so all of our staff have their policies and procedures at the hospital at their fingertips, everything from HR to nursing, policies and procedure, every department. So we're going to showcase that at the National Convention here in the next few weeks. So good stuff.
I would say as a supervisor, one thing I do like about it also is it's, I'm supervising areas that I don't know much about, and everything that I need to know about them is in SQSS. So I know who's doing what, if it's being done appropriately, on a timely basis, and that helps so much.
And on that note, so if somebody is sick or dies or is gone for an extended period of time, the things that they're responsible for flow to the next person that it's been built. So if I'm gone, my task would fall to Angelica if it was built for her to do that. And so it keeps you from, not knowing about something going on that you should have, and come survey time, you're like, oh gosh, and feeling stupid. I mean, it really does allow you to wrap your arms around your processes. Anyway, you've got the report. I won't go over it. It's quite thick of the things that we're working on through those processes. And if there's anything that you see that you need more explanation on, be happy to try to answer those or give you an answer for those.
Okay. Next item would be improvement to patient care. There's the contract review under the patient care tab.
So we had 4 contracts that were reviewed and 1 that was archived, and all of those are compliant and approved. And then there was one for June, it looks like we've got in here, that was July, and those were 100% on all of those. It's a Medicare requirement that we review our contracts on an annual basis to ensure compliance with the language in the contract. So it helps us lay eyes on all of our contracts on an annual basis.
Any questions about that? If not, next item is discussion action to approve or disapprove the revisions report dated August 4th, 2022. Anything about that?
Coming through, seeing which ones they were. Revisions report is all of those policies and procedures, either new or majorly tweaked policies that come through the policy committee. Those have to go through med staff and then to AHA for approval.
Make a motion to approve the revisions report dated August 4th, 2022. Second.
We have a motion by Dr. Brown, a second by Greg Bowman, to approve the revisions report dated August 4th, 2022. Roll call vote, please.
Jasper,
Yes.
Hannaford,
Yes.
Bert,
Yes.
Simon,
Yes.
Brown,
Yes.
Bowman.
Yes.
Okay. The next item is discussion and action to approve or disapprove the small balance adjustment policy.
There's a motion that we approve the small balance adjustment policy.
Second.
4 times.
Yes, it is. Thank you.
Okay, I have a motion by Dr. Brown, a second by Dr. Hannaford to approve the small balance adjustment policy. Roll call vote, please.
Hannaford,
Yes.
Bert,
Yes.
Simon,
Yes.
Brown,
Yes.
Bowman,
Yes.
Capron.
Yes. Okay, thank you. Next is the shared convalescent home report.
You can see the stats up there at the top. We did have a slight increase in census from July to June, but it was, very slight. It'll be less than that for August when we report next month. The things I want to point out, our nurse call system. The system, I think most of you, some of this is going to be a repeat for some of you, but our system tracks how long it takes us to respond to a call light. Once the resident hits the button, how long does it take us to get in there and reset the call by answering the light. We shoot for a goal on average of 4 minutes and 30 seconds, so nobody waits more than 5 minutes, and we've just been rocking it. The average time in July was 2 minutes and 49 seconds. That was up from 2 minutes and 30 seconds in the month of June. So we haven't strung together 2 months like that since we've had the system, and it's just been really great. I really put an emphasis with the staff and the DON on not having any calls go over 15 minutes. 0 calls over 15 minutes, and we achieved that for 2 months in a row. So
Are these goals now national averages?
those were our goals. I don't know what the national averages are.
I just didn't know what the,
What do you attribute the decrease to?
Just attention to the,
Goal?
attention to the amount of time. If you have 2 or 3 that just don't get answered for we found out that we had some issues with our pagers that hadn't made it up to people that could do something about it. So we got those issues taken care of. We also had some issues with the desk monitors, and so between those 2 things, we were able to see, quite a bit of improvement. But also, it could be on the verge of neglectful if you're sitting at the desk and you don't answer a call, and so we put a major emphasis on that as well. So I think all those things combined, making sure that they had the tools and resources to be able to do the job that we expect them to do, and then reminding them over and over again the importance of it.
I think it's neat that you have the ability to qualify it and quantify it.
Yeah,
I mean,
well,
it really is.
If someone has to wait 15 minutes on somebody to respond to their call, our clientele may not wait, and they may get up and they may fall, and that's even worse. And so, not all of our residents know how to use their call light, but the ones that do, we need to make sure and take care of it. We are looking to add a feature that will give us cues and reminders to go check on those that aren't able to use the call for assistance. So there's nothing really out there that's going to, we haven't found it yet. I'm sure it's out there. We haven't found it yet that would make that call automatically and integrate with our system. And so that's kind of what we're looking for. But we had a situation where there was one resident that was needing extra attention, and we were providing that, and we were doing exactly what we should have been doing for that resident. But in the meantime, some of our residents that aren't able to push their button, they went a lot longer to get attention than what we would have wanted them to. And so we're looking for that's going to be a constant cue that, we could set up to every hour, every 2 hours, whatever it may be, that we're always going to go in and check on them and reset the switch, if you will, so that we don't let anybody go for longer than they should. So, and I think honestly, by answering the calls more quickly, I think they're making more time. They're having more time to go answer those other calls as well, the non-calls as well. So, but yeah, I'm really proud of them for that. like I said, the average was 2 minutes 49 seconds, but almost 83% of our calls are less than 5 minutes. So, I'll also point out, and Candace and I looked at this in July a little bit, just because the staffing issue is such an issue, and you know, we want to make sure that if there's anything we can be doing that we're not doing, that we're taking care of that. And you can see down here that 100% organization advocate, those are the people that would recommend us as a place to work for their friends and family. It's also 100% organization advocate for those that would recommend us as a place for care for their friends or family. So I feel like, you know, we're hitting the mark there. Our new employees, when we onboard them, they all have, you know, wonderful things to say about us, and then we also score very high in terms of teamwork. Where we don't, and we feel even though, and so those three areas, teamwork, new experience, and organization advocate, we're exceeding the benchmark in all those areas for the company that does our satisfaction surveys. We're really close in terms of, we're like 1% off the benchmark with feeling safe and comfortable at work. That really took a dive when COVID hit. They didn't know, you know, if they were all, everybody thought they were going to get COVID because they worked in a nursing home, and you know, we've, you know, changed that culture, that mentality, and so everybody feels safe at work. But the two areas that are, you know, the least impressive are, do they feel appreciated for the job they do, and what's their overall job satisfaction. So if you take that overall job satisfaction at 63% is where we're at, and, you know, these other areas we're 94, 95, 100, 100. To go 63%, it's not good, but the national benchmark is 66. So what that tells me is that nursing home work is just really hard, and people are, I mean, they are more likely to burn out and those kind of things. And so we have, in the past month, taken some time to really hone in on some employee appreciation things. We're doing Spirit Week right now for homecoming. I did wear closed-toed shoes today, but yesterday it was red, white, and blue. And so we're, you know, trying to do those things. We're trying to do things that are going to reward the outcomes that we're wanting them to achieve and that they are achieving. And we're trying to just offer, you know, little things here and there as well that, you know, a weekly drawing or, you know, something like that, to where they don't get to the point where they're burned out and they can't work for us anymore because it's just too much. Because it is a tough job. And so I'm anxious to see if we can move the needle on some of those things and make it a more pleasant job for them. It's not going to be an easier job, but maybe they'll just get enough in their, they'll fill their cup up enough that they've got enough left for them. So that's what we're shooting for. We did, on other things, we did have our, I would say, annual survey, but it had been since 2019 since we'd had a survey. I don't know that I reported this in June. It was just wrapping up in June, but we cut our number of deficiencies more than half from what we had in 2019. Still not, you know, still have some things to work on, but our scope and severity level was lower than it was before too. So fewer things that they found, and it was less severe what they found. So
I think 3 years.
Yeah, it'd been 3 years.
When you're used to an annual survey, and that kind of keeps you on your toes with things, I think that
a lot of the things that they were saying that they were catching nationwide were, or statewide, were infection control related, and we didn't have as many of those as, what, some of the places we're experiencing. And so I feel good about that. We had some little things, and it was documentation related. It wasn't that people didn't get the care they needed, but we had some things that weren't signed. We had some stuff like that. I mean, we had evidence that people were taken care of, that we missed a few things, didn't cross all our T's and dot all our I's, and they found some of those. So, Candace mentioned SQSS, and it was a godsend when we had them on site, because they come in and they hand you a list of things. We want these things and we want them now, or we want these before the first hour is up. We want these by noon, and we want these by the end of the first day. And I just took the list and I sat down and I started assigning people in SQSS, and we didn't lose track of it. That was 3 pages worth of stuff they wanted, and got it all put into SQSS, and by the end of the first day they had everything they wanted from us, and I left town.
Yeah, he was leaving town, of course.
Yeah, I wasn't supposed to even be there that day, but and that system really helped make sure that we were able to take care of what we needed to take care of, and then the staff did a great job with everything. We didn't have any, no patient harm, none of that, so it was good. And so with that, we have just this week, yesterday and today, wrapped up sending. So we sent in our plan of correction. They approved our plan of correction in July, and then we had through middle of August to implement everything. And then just this week, rather than do a return visit, they asked us to send back a desk audit. And so we just completed that. And assuming they like what we sent them, that shows how we fixed all the issues that they had. Then we'll be done until the next time they come to survey us, which, if it's an annual, it should be next year, but who knows? They can't find help either. We did, I'll leave it at that, and if you guys have any questions, I think I mentioned earlier we did have some agency expenses in July and August, so that's reflected in here. Any questions about the nursing home report?
No? Kelly, thank you for that. Anything else to report on the homestead other than the financials?
I will say that the maintenance guys have been doing a great job. They've been trimming trees and really working on some landscaping things, and it's looking really good what they've been doing. And there have been several air conditioners, that have met their maker here towards the end of summer, and so they've been working on that. If you'll remember the flood that happened in one of the apartments due to a plumbing issue, the contractors are getting out and wrapping all of that up now, getting that taken care of, but that's through the city. They're getting that taken care of, and they've had a couple move-ins in August. Let's see if I'm sure I missed anything. I mentioned that we were advertising. It's in the Enid News and Eagle does a medical directory, and we've had for the last, 6-8 years, we've been advertising in that, and we always get at least one referral that's how they learned about us, and that more than pays for the ad. So we've just made it a habit of every time they put that out, we get in it, and so we just did that again.
Any other things for the homestead? No. How about the foundation? Anything there?
No.
Nope. All right. Kelly, thank you for your reports. St. Anthony's give you anything to report? No?
I got sick of the last one.
Okay. Greg, council report?
Bear with me. In
It was a pretty long meeting, but it was a pretty short meeting. Most of it had to do with employees and staffing. We were in executive session discussing that, on how we can balance people and balance the departments. We have a new grant writer. What's the name?
Stephanie Whiting.
Stephanie Whiting. I intended on sitting down with her. She's got a whole list of grants she's working on. One that really intrigued me was the Safe Trails, where they're looking at routes for our students to, you know, safely go, like from the BAP, where a lot of those kids are walking down the highway, there's no sidewalks, or, you know, and then throughout town. So she's got a whole list of grant stuff, whether it be the park, the swimming pool, and so she jumped in with both feet and is doing a really good job. Street projects, we're fixing to start a new project Thursday. Flynn Street and I believe Skyline has the possibility of being closed. We're working with Woods County, a new process of chipping and sealing, which, you know, there's a lot of people say yay or nay. Well, you can do a whole lot more streets with chip and seal than you can grinding it up and doing a blacktop. So this new process, in fact, I got to watch them do it on Highway 64 out towards Beaver. So anyway, working with Woods County, we're going to be doing those two streets. The segregation of the transfer station should be completed here pretty quick. That was due to the fire that happened a few months ago. The, you know, people going out there. So it's going to be locked down now. You know, you can only go out there and dump during business hours, and it looks really good. And that's about it.
So on Thursday, that's from what street to what street on Flynn?
10th to Skyline.
10th to Skyline.
Okay. All right.
Don't drive Locust between 7th and 8th.
I'll be to the high school park.
We're going to use the south, not the north.
Locust Street was put on hold because the county had people available to do this chip seal, so they pulled off of one
Wish
to...
they had found that out about 2 days before.
Chain Justice gave me an earful.
Okay. Well, Greg, thank you for your report. Two things. One, at the very beginning of the meeting, I should have welcomed Drew Cunningham to the board as our counsel, and so we welcome you.
Thank you.
You're a lot nicer than your dad was, but anyway.
Start out.
Yeah. Welcome, and thank you for your interest in wanting to serve here on the HA and helping us out. Appreciate it.
Thank you. Excited to help out.
The other item is on September 28th. There will be a reception for Dr. Self. He will be retiring, and so you might put that on your calendars. You think it's 1 to 3?
I think it's 1 to 3, but all of that conversation happened in person and nothing in text or email. So I
It's been in the paper.
Huh?
It's been in the paper already.
I just put it in the paper.
I'm fixing to look it up. I just put it on today's paper, but it won't be printed until later.
It's newsgram.
I've seen it.
I was gonna say, it's in the
It's in the
newsgram.
newsgram.
I had it down 2 to 3.
Oh.
That sounds more like what I remember it being.
September.
But it's
Like
like
in the middle of the afternoon.
It's gonna be actually in our lobby, is where we're gonna do it. And we'll have all kinds of goodies and come out. I think it's from 1 to 3, but I want her to confirm it.
Hang on.
Because
I'm getting there.
I don't trust my memory to confirm that, but we,
2 to 3:30 on September 30th.
2 to 3:30.
Well, it's not even right. What day is
On
it?
what?
I mean, September 20, well, it says continue to see patients, September 28th, sorry.
September 28th from 2 to 3:30?
Yep.
Okay, thank you so much for
You're
that.
welcome.
So we'll have goodies. I will also be taking, does this have to be recorded? I don't want him to find out. Can we
We're in the new
adjourn?
business.
Can we adjourn and then we
I
say
was gonna
it?
say, it doesn't have to occur during.
Yeah,
Yeah.
that's a
I'll-
non-business item.
It's non-business.
Okay.
It's for us, so I'll go to that after you adjourn the meeting.
Yeah.
I didn't want him to watch it and find out,
I
or.
think he watches these.
Well, either way, it doesn't.
Somebody might, you never know.
Did you hear what they're doing?
At this point,
Yeah.
somebody's gonna say there's something up.
Okay.
Doctors, they don't have anything else to do.
There were no other items of new business, so we are adjourned.